my talk is going to be focusing on, let me just close this out here, perioperative data access and equity in low-resourced environments. I'm going to first and foremost go ahead and disclose our funding sources. Currently, we are funded through the Lacuna Fund, which is primarily to create open-label, machine-readable data sets for low-middle-income countries. And then we have received funding from the Center for Global Health and Equity for some of this work. So those are the disclosures that are directly related to the work I'm going to talk about. So let's start by an overview of the talk here. First and foremost, I'm going to spend a few minutes talking about data generation and really how it pertains to the perioperative setting. Then I'm going to focus on some of the sources of data in healthcare, and then how we leverage data to improve research, quality of care, and patient interventions. And then really pivot to the challenges we faced with data access in low-middle-income countries. And really some of the novel ways that practitioners in low-middle-income countries have overcome some of this data limitation and data access problems. But certainly there's a lot more that we can do. And we're proposing one mechanism, but I think there's so many interesting and novel ideas out there. And then finally, sort of focusing particularly on the hot button topic of AI in the perioperative settings and sort of seeing the synergism in terms of how to improve data access and equity. So let's dive right in. So, in this day and age, it's really the amount of data that's generated every minute is gargantuan. And it's really hard to wrap one's mind around how much data is generated. And so, this infographic really provides some sort of tangible numbers. And so if you think about it, I'm talking about every minute now. So every minute, there's about 41 million WhatsApp messages that are sent. That's just WhatsApp. And then about 1.5 million video calls that are made, video stream, about 500,000 video streaming occurring continuously every minute, 347,000 stories posted on Instagram, Facebook post, as well as sort of 147 Facebook users. I mean, I'm virtually sure that every one of us on this call has contributed to some of that data that you see there, right? And so this is ubiquitous. It's part of our life. It's become the fabric of our life, right? And so the question is, how much data does that all generate? And so this next bullet point 2 sort of really takes it to to the next level. The estimated data consumption from 2021 to 2024 went from 74 zettabytes to 149 zettabytes. Now this talk would be incomplete if I didn't figure out what a zettabyte was. And so the easiest way to figure out what a zettabyte was is that I went to ChatGPT, right? And I went to ChatGPT and said, how much is 1 zettabyte? And this is what it turned out. 1 zettabyte could hold roughly 250 trillion. That's with a T, not with a B, not with an M, but with a T. 250 trillion songs in MP3 format, or about 13.3 billion years of continuous HD video. Now, I may be aging myself, but I remember in the early to mid 90s trying to download one song on a dial-up connection, right? And you can sort of, if you use that as the reference point, you can just think about the amount of data that's generated. And if you just drive up to Northern Virginia as an example, the amount of data warehouses that you see now is really exploding. And so that's really reflective of the amount of data that's generated. This takes a slightly different view of it. It sort of tries to pinpoint where a lot of that data is coming from. And a lot of it is driven through social media and video streaming services. But the one things a couple of things that we don't really realize is the amount of data that's generated in cars now, and self-driving cars. Just think about the amount of data that comes from self-driving cars, the ability to understand the environment and respond appropriately to that environment. And then wearables. Virtually all of us at some point either have a phone or we have some wearable devices, and think about the amount of data that comes from these wearable devices. So let's take a slightly different view and say, okay, what does data in healthcare look like? And so, sort of the data is very varied, but on average, an average size hospital, right, would generate about 50 petabytes of data every year. So once again, we plug that into ChatGPT and say, okay, how much is 1 petabyte? Well, 1 petabyte is about 250 million songs in MP3 format, or about 13.3 years of continuous HD streaming. So once again, that's a gargantuan amount of information. If you go back, this is 13.3 billion years of streaming. This is 13.3 years of streaming. So just one average size hospital is generating a ton of information. The question is, where does that data come from? And so if you think about it, just think about your own practice, and you're like, well, that's true. There's a lot of data that's generated in healthcare. Electronic medical records, that probably is by far the greatest generation of data in a healthcare setting. And then if you just think about imaging data, right? You take a tiny little picture on a smartphone, right? And think how much, that's what, 4 to 8 megabytes. Well, now you're doing MRI, CT, PET scans, imaging. Suddenly that's explosive growth in data, right? And then, of course, if you merge that with genomic, metabolic, and omics data, now you're starting to see that how you can exponentially increase data in the perioperative, in the hospital setting. That's just looking at sort of the health, sort of the health system side of data. Think about what we're doing from a patient point of view, right? Patient-reported outcomes, the use of sensors, right? We're participating in a large PCORI-funded study where our next step after the initial feasibility stage is to give everyone a smart, either a Fitbit to collect post-operative data. Once again, that generates a lot of data. And then obviously all the data that's generated in online communities where there's sort of this communal hive mind where patients sort of look for information. And all of that generates a significant amount of data. So now let's take all of that and focus on the thing that makes us sort of interested in this work. So let's look at the surgical encounter. And if you think about surgical data in the perioperative settings, if you take an index case, take an appendectomy as an example, the patient has a set of historical encounters, then they have an acute event. That event you get seen by the ED, you get seen by the surgeon, there's an anesthesia encounter, there's a post-operative encounter, and then the patient gets home and there's some sort of follow-up. That's a relatively straightforward encounter. But each of those steps, once again, generates a lot of data. And I'm going to break down what the current state of the data looks like from each component. So I'm an anesthesiologist, so I'm going to start by focusing on some of the anesthesia data. So some of you may be aware of an organization called the Multi-Center Perioperative Outcomes Group. This is an organization that's been in existence well over 10 years. You can see that University of Utah right there, I can confidently say, was one of the first organizations that sort of bought into MPOG's philosophy. Right now, over 80 academic as well as private hospitals, all funded through Blue Cross Blue Shield in Michigan, participate. And what do we do? We take anesthesia data, so intraoperative anesthesia data. And if you think about anesthesia data, that's data density. Like you think about how much data is generated per minute. And Marcel, who's on this call right now, he and I wrote an article and just sort of tried to distill the density of data that's generated either in an ICU or in an intraoperative setting. And you just start to think, right? Minute to minute data. If you have an arterial line, that's second to second data, all medication data, all the written text, that generates a bunch of data. So what MPOG does is takes all of that data and semantically deconstructs it and maps it into a common language. So every feature gets remapped to some sort of common language so that everyone, whether you're a Cerner or you're Epic or some sort of electronic health record system that I can't even think about because those are really the dominant market players, all gets semantically mapped to common language. And then we de-identify the data, clean it and we send it up to Michigan where it gets stored. So right now, that's 26 million cases over the last 12 years, 452 million medication records, and 58 billion physiological observations. Healthcare data can rarely be, particularly anesthesia data, can never really claim to be big data, because big data sort of sits in that realm of like Google's data. But we're starting to dip our toes into the volume of data that's available. So right now, within that data set is just it's a rich an anesthesia repository. And this anesthesia data is just not anesthesia data. It's the preoperative demographic data. It is Ilix-Hauser comorbidities that sort of classifies the patient's comorbidities. It's prophy data, right? So we know what the surgical CPT codes are. We know what the anesthesia CPT codes are. We have admission ICD diagnosis. We have discharge ICD diagnosis. And we have all the laboratory data as well. So you can see it pretty much encompasses the entire surgical encounter. So what do we use that data for? Well, one is improving quality in the care that we provide. Yeah, I mean, this is the, so if you take the patient as the true north, right? I mean, what we should always strive to improve the patient quality of care. And so here what we do is that, we have 84 anesthesia specific metrics that we measure across the institution, and we benchmark them. You can see this. We, the blue ones, all the other ones are de-identified. And this is looking at one specific measure, preventing hypotension intraoperatively. That sits directly in the care of the anesthesiologist. We are responsible to make sure that the patient is not hypotensive. Right? There are other things that are beyond our control. But this particular encounter, the ability to keep a blood pressure above a threshold, is really in the realm, and we should be taking responsibility for that. And you can see that we can benchmark ourselves according to other institutions, and then I can actually benchmark providers within our institution as well. So here's data being leveraged for quality improvement. Here's the individual responsibility, right? So every month I get a report that says, hey, Pekan, for these 3 measures as an institution, this is how you did for nausea and vomiting, how you did for blood pressure, and how you prevented hypothermia. And here's this is you, and this is your cohort that we're comparing you to. There's a sense of accountability, and there's a sense of following the data to improve outcomes. What about research? Here's a rich source of data. Right? And I will say that there is a really very well matured research proposal and submission and acceptance process that goes in. But I'm going to show you some of the studies that are published, and they are a lot, right? And so here's just all the studies that are directly attributable to the MPOC data set. These are all, and these are just the ones that are published. There are probably another 15 or 20 that are in the various pipelines of admissions, paper submission, revisions, right? What's another way we can use data? Well, so think about if you take the data and you build a platform that sits on top of the data, that takes the data and actually curates it into predefined logic that actually helps the provider. Right? So all these things I showed you, the research and the quality, those are all what we would say retrospective. We get the data reports at the end of the month or at the end of the quarter. But what about using the data to implement changes in real time? And so this is a company called AlertWatch that takes data from your electronic medical record and immediately sort of organizes it into the sort of infographic here, right? And this is actually all in real time. And it's telling you, as an example, that for this case right here, you've got 12 minutes of cumulative hypotension, right? And you can sort of look at lab values, you can look at your fluid balances. So in the face of information overload, it distills that information and provides it into a digestible, understandable form of patient encounter and patient, sort of intervention. And if you take it a step further, think about if you're getting all of this data coming into from each. This is one OR, right? And if you think about it, if you at your hospital, there may be 50 plus ORs, right? What happens if you take 2 or 3 anesthesia providers, whether they experience CRNAs or an anesthesiologist, and then you put them into a control room, right? Like an EICU. And then you say, hey, instead of just one provider in a room looking at the screen, we provide a second layer of real-time alerts and intervention, very much like an air traffic control system, right? And this is what the anesthesia control tower study is. This is an NIH-funded study from Michael Avidan's group at WashU. And what they're looking at is a control room mechanism to improve patient outcome. Once again, data driving clinical practices, early warning systems, early interventions, and hopefully improve patient outcome. I'm going to take a different lens now. So I sort of focused a lot on anesthesia, but what about the surgical, sort of data that comes specifically from the surgeons? And so the ACS NSQIP is really a phenomenal database, right? And once again, it's abstracted data, it's risk adjusted, it's case mix adjusted, and it has 50-day patient outcome data. And I just pulled this from the ACS website. Hospitals that use the ACS NSQIP database, 62% reduction in morbidity, 71% reduction in mortality, and you prevent between 200 to 500 complications annually. What else comes from the ACS NSQIP database? Well, the ACS NSQIP risk calculator, we use it all the time. It's a mechanism to identify patients at potential risk of increased complications post-operatively. And more importantly, we provide a patient-centric risk profile to patients, and they understand sort of what the expected post-operative risk looks like. Now, if you take both the MPOC database and you take the NSQIP database and you decide to integrate it, think about the power of combined data registries. And so here's an infographic of, if you take an anesthesiology clinical champion, a surgical clinical champion, and then you've got the IT infrastructure, and you integrate all of that into this pipeline, you can actually then take MPOC data, NSQIP data, STS data, as well as STS thoracic and cardiac data, and really create a data set that's further enriched by the strengths of both those data sets. And so, as an example, here's a paper that we published recently where we looked at airway driving pressures and post-operative pulmonary complications. The results don't matter here. The most important thing, though, is that we took the MPOC data set and we merged it with the NSQIP database. And now suddenly you can see the power of those two data sets. And you can see that once you combine we had 41,000 patients and there was a bunch of, sort of exclusions. We have 41,000 patients who have that rich MPOC data set with those abstracted, sort of someone who's actually gone through the chart instead of this automated, which is classic for the NSQIP database. And you can really hang your hat on high quality data. What we did here was we looked at tidal volumes, which is data we got from the MPOC database, and we merged them with the STS thoracic database. And you can see, once again, really rich data enriched by abstracted surgical registry data. Same thing with the STS cardiac data set. Okay, so that was just a tour de force in terms of how great it is in high-income countries. We really live in a lap of luxury. It's literally, if we want the data, we need to ask for it, and it's there. Now let's look at what the reality is for surgery-related data in low-middle income countries. And I thought this was a really interesting paper. This was published in the British Journal of Surgery about 4 years ago. There's 2 panels here. The first panel is the number of studies in low-middle income countries. And number 2 is the number of patients per LMIC study. All right. And what I really want you to focus on, if you exclude China and you exclude Brazil, and let's focus on Africa as an example, the number of studies is pretty low, right? South Africa obviously stands out as an outlier, but for the rest of the continent, the amount of studies that are generated are pretty low. Then if you sort of pivot to the idea of big data studies, and I use the term loosely, and I know people may take exception to what big data is, but I'm just talking about the number of patients per study group. Once again, if you exclude Brazil and China and even India, the rest of Africa, the number of patients are pretty small, considering the number of just the incredible number of patients that are done in these countries and at these sites here. Sudha, do you have a question?
Yeah, do you know if this study included things like the African surgical outcome study or the
ASOS study?
Yeah, ASOS or Global Surge. I'm curious. I don't know.
I suspect it probably didn't include ASOS because this was published in 2019. And so I suspect it doesn't have that sort of that data included. Good question.
Yeah, thank you.
So once again, you can see that just that based on the number of patients that are done, the number of studies that are coming out, there's quite a big disproportionate gap between the two. And so part of the issue is that the ability to get access to digital data in low middle income countries is extremely challenging. I mean, that's the reality of life in low middle income countries. And I think we've all worked or visited some place in sort of sub-Saharan Africa or in low middle income countries. What strikes you is the lack of resources and infrastructure. If you want to implement an electronic health record system, it's important to understand that it's just not the implementation. It's implementation, it's maintenance, it's troubleshooting the whole system. And in the back end, if you think about your own hospital, the number of emails you get per day saying that something's gone down and something's come back up, right? For all the times that some electronic health record infrastructure has gone down, you need a team of information technologists and bioinformaticians to fix that. And that, unfortunately, is lacking. The cost of implementation and maintenance of electronic health record systems is pretty prohibitive in most countries. And then obviously the things that we don't think about, but it clearly is an issue at a national level, is just the regulatory requirements for data governance. Sort of, if you think of MPOG as a structure where we decided that we're all going to take our data and we're going to find a mechanism where we're going to upload 26 million records. Now think about that. If you try to do that on a national level, that would be pretty tricky from different governmental requirements. And I'm not saying they're wrong. They're each trying to protect patient identity, patient confidentiality, but it becomes a Herculean task to sort of break down those barriers. The next thing is that what are the most important surgical data features that we need to collect? Unfortunately, we can't collect everything, right? And so the question is, what are the data features that we should be collecting? And so I think the first step, and I think this was a really interesting study. This is one of our collaborators, Hyla Klutz and Bruce Picard. They published this really interesting study, which is really determining the minimal data set for surgical patients in Africa. And I think that's an important first step that we need to take. We can't get everything. And if in our attempt to get everything, we're going to fail and get nothing. So the question is, what is a minimal data set? And I think they did a really incredible job using a Delphi approach to define what is the minimum anesthesia surgical features that need to be collected to improve patient care. And if you haven't read this paper, I think you can. There's a couple of tables that really highlight the key data features that we need to be collected. The other ways we can get around the issue of data access and equity is the use of open source electronic health records. The most common one, or the one that has the highest penetrance, is OpenMRS. This is definitely an electronic health record system that is designed to be implemented in low resource settings and can potentially be utilized for some of the work we're talking about. Hey, Sudha, you have a question?
Mo had a question before we move on from the section.
Oh, sure.
Mo, do you want to jump in before we?
Yeah. I just don't want to lose the opportunity to ask a question while you were talking about the cost. and I'm not sure if you are able to respond or not, but do you have any idea how much it will cost? Because you were saying that the EHRs are cost prohibitive for low-income countries. I'm originally from Morocco, so I know the situation very well. But do you have any idea how much, for instance, it will cost a country per patients or per inhabitant? Or
Yeah, that's a good yeah, that's a great question. And in all honesty, I think each one depends on, sort of what each country's sort of requirements are. In all honesty, I don't know what the per patient costs would be.
Actually, I'll jump in, not from a per patient cost standpoint, but per institution cost. I was just looking at this yesterday, and I can't remember where I was looking at. And I saw a range of numbers per hospital level, like per hospital. It's anywhere between like 5 million to like 12 million, depending on the size of the hospital. And I think this was a LinkedIn post, actually, of someone making the point that EHRs are not going to solve everybody's problems because they are incredibly expensive at the least. And they're not the panacea that the big two epic concern are, potentially making it out to be, for whatever. So, that's at single institution level. So enormous amount of cost.
Well, thanks for providing that information, Sudha. So, so obviously the other sources are open MRS, which is significantly less, but not free by any stretch of the imagination. So then what have people done to sort of circumnavigate some of these limitations? And so, like I said, clinicians are extremely resourceful, and where there's a will, there's a way. And so this was a work done by Ben Salashi out of Vanderbilt. And so what they looked at was, they were looking at anesthesia care delivery and outcomes in Kenya. And I really liked what they did. They used iPad, infrastructure and a RedCap database. And they were well aware that there was interrupted, internet connectivity. So they had a mechanism that when there was no internet, the data was stored locally on the iPad and then got uploaded. Once again, they were very intentional in just choosing limited data features. And what I want to show is that utilizing over about a year and a half, single center with data manually entered into a RedCap database, they managed to get data on about 6,000 patients. That's really an incredible achievement, right? From a single center over a year and a half, with defining a very finite, limited data set. So that's definitely one mechanism of trying to circumnavigate the limited access of digital data. I want to talk about some of the work that Bruce has been doing together with the APOG network. So, and I think that's important to understand, because once again, when you talk to Bruce, they're very intentional in the way they design their studies. They are, first and foremost, they know that depending on the goodwill of the clinicians that they're working with, there's very little to no funding. In fact, for a lot of this work, there was no funding. And what they did was they tried not to overburden the providers. And so if you look at the CRF, the case report forms, one page, very, very intentional, and every data element was going to be used in their analysis, right? And so the CRF was designed with the outcomes in mind. And I think ASOS was a game changer in terms of understanding perioperative surgical mortality in low middle income countries. And if you think back to your epidemiological sort of this thing, it's really truly a prospective observational cross-sectional study. They took 7 days at various points, different hospitals at different time periods, but they just took a epoch of time, a cross-sectional window, and then collected data. And once again, a really interesting study design once again, I know this is small, 11,422 patients included in the study. Look at the buy-in that they got across Sub-Saharan and North Africa as well. Incredible amount of data that actually drove some really interesting findings. Using that same study design, what they did was they did the ACOS study for patients with COVID infections, 3,140 patients recruited in that study. And finally, so the idea that if you don't have an electronic health record or some sort of digitized data health system or infrastructure, you can't do research is not true, because these investigators working with limited resources and depending on the goodwill of their partners have demonstrated they can do incredibly high quality work with very, very limited resources and have some amazing outcomes. So then the next question is that how do we continue to improve the data access and equity issue in low middle income countries? And so the one thing to realize is that mobile health solutions, smartphones, are really probably the pipeline to some of the problems that I've highlighted earlier. So what is it about smartphones that make them so attractive? Number one, rapid growth. 3/4 of the population of Sub-Saharan Africa live in some area that there's mobile connectivity. In some areas, it's probably better than north in the US. I mean, I live in an area where I can hardly get any internet connectivity. I mean, number two, affordability. If you look at the cost of smartphones in low middle income countries, the quality of the product and the cost of the product are definitely getting better, right? So you get a high quality phone and it costs significantly less than what it did 5-10 years ago. High penetrance, like I said, mobile internet penetration, 26% of the population in 2020. And you think about what people use the phones for, social media and messaging. I mean, if you talk to Bruce and Hyla, ASOS was essentially run on a WhatsApp platform. I mean, the entire infrastructure running that study was run on WhatsApp. Amazing. I mean, just groundbreaking type of work. Mobile banking and financial services, leveling the playing fields for e-banking and e-commerce. Unbelievable in terms of what mobile health has done. And then the third part of it, which we're starting to really understand the value of it, is sort of the onboard sensors. Yes, it's intrusive, and I think there obviously has to be boundaries, but the ability to capture data, geolocate data, geospatial data is really is groundbreaking and potential for significant research moving forward. And then AI has become a buzzword over the last 2 years, right? And so the question is, what is AI? I'm struggling to understand what AI is. It's moving. If there's a disruption in the field we do, this is the true disruptor, right? Within the last 2 to 3 years, AI has been a major disruptor. And AI has got different components. There's machine learning, there's neural networks, there's natural language processing, there's robotics. All of them have slightly different flavors. What I would strongly suggest is people read, I think, 2 really interesting statements, one from the World Health Organization called Recommendations on Digital Interventions for Health System Strengthening. And then together with that, the AI in Global Health through the Rockefeller Foundation and USAID. It really sets the stage of how we should be doing digital interventions and how AI should be leveraged in low middle income countries or low resource settings. Once again, we have to be very intentional because biases that have traditionally existed in healthcare can be further perpetuated if we're not intentional in the work that we do. So for the last sort of 5-6 minutes, I'm going to focus on just a little bit of the work we're doing. And so there's a specific form of AI called computer vision. Computer vision is really a form of AI that extracts information from images. So if you look at this image, we, within a nanosecond, can guess that that is a bird. But if you give it to a computer, what is the mechanism that the computer can use to figure out that that's a bird? And so here, it's using a deep learning convolutional neural network, and then it's given several outputs, and then through learning, it'll figure out that this is a bird, not a cat or a dog, right? If you have a self-driving car, well, there's no true self-driving cars, but Waymo or Tesla, that they claim they have self-driving, needs to understand the environment that it's driving in. Like moving down the street, it needs to understand that those are houses, those are cars, what's are buildings, what are fences, and that is what computer vision deep learning is all about. This paper I thought was just blew my mind when I first read it. This was a paper, I don't know if you've had an opportunity to read it, was a development and validation of a deep learning model for diabetic retinopathy based on retinal fundoscopy. Okay, if you talk to an ophthalmologist, reading fundoscopy for retinopathy is the bane of their existence. They hate it. They absolutely hate it because it takes so much work, and it just is an incredibly difficult thing to figure out which patients have diabetic retinopathy. Figuring it out is important because those patients need to be referred for future interventions, monitoring, better glycemic control. But it is the bane of their existence. And so this was the first computer vision deep learning model that was created to understand images of your retina for diabetic retinopathy. And so essentially what you have here are this is a receiver operating characteristic curve. This looks like a really great curve if you understand ROC curves. But what is important to understand is that there's an ophthalmologist, which are all these people right here. All the colored circles are all ophthalmologists essentially classifying whether a patient has diabetic retinopathy based on an imaging. And the black dots right there, the black triangles, are essentially the AI model. And the AI model is as good, if not better, at the human in picking up diabetic retinopathy. Game changer, absolute game changer, right? And now just see what's happening in low middle income countries using computer vision and deep learning. So this was, I thought, a really cool study. What these guys did is that they took a rubber stamp. They just took an old-fashioned rubber stamp, and it had a whole slew of different demographic features, right? And blood pressure features. And all they did was just color the block to define each of those characteristics. That's it. And then they took a photograph, you can see it's from a phone, and they used computer vision deep learning to then classify each of those dots. So when it was circled, it was green. When it was not circled, it was orange. And as soon as it was identified, it was then classified as a positive, and then you knew that at that point, if that was marked, the patient had an age greater than 55, an example. Amazing. So what this group did was not to, didn't want an electronic health record system. They sort of talked about this hybrid system where digital is not going to get rid of paperless. It's the sort of conduit, right? You take paper, you use some sort of digital AI solution, and then you get the end product, which is some sort of digitized database. Now think about some of the work that we do, right? This is an anesthesia record. If you go to the ICU, it looks exactly the same. There's nothing really different between an anesthesia and an ICU chart. And each anesthesia ICU chart has a bunch of features: medication, volatile, IV, blood pressure, physiological data. So it's a lot more complicated than that earlier chart we talked about right here. You can see this is a relatively straightforward chart. An anesthesia or an ICU chart is a lot more complicated. And so what we've worked on now is taking an ICU anesthesia chart, uploading it, running a series of AI models on it, and then churning out a series of outputs. And I'm going to briefly talk about how we do that. So what we do is we take the picture of the anesthesia chart and we optimize it. Once again, we were very intentional that we don't want to disrupt the workflow of the people who are doing the work. You could take a chart and ask them to find a flatbed scanner and optimize the image. It's never going to work. It's doomed to failure. You want the work to be aligned with their workflow. And so just taking an image is fine. But of course, we've all taken photographs and like, oh my goodness, that's a terrible, terrible picture. Once again, we want to do the work. And so we've developed what are features called planar homography. And I'll just show you briefly how we take those images and we optimize them. Then we extract each section of the chart. And then we run models, modular models for each component of those anesthesia charts. And then we churn out an output. So here's an original image. You can see how dilated and blurred it is. But then what we do is we run a feature called homography on it. And what it does is you can see it completely optimizes it. It looks better from the human eye. From a machine reading point of view, it's a game changer, right? And what essentially it does is that if you think about an image that's taken at an angle from your phone and it's warped, what we do is this homography takes it and sort of realigns it to create a 4-point flat image. Because that's important, because what that does is that if your blood pressures are not aligned, you're going to get false readings on that. So those are some of the important features to it. So here's an example, before homography and after homography, where the images now are ready for the AI models to run through them. Then we use what you call YOLO models, which are really off-the-shelf models that essentially take different components of the anesthesia chart and then split them out into different models that we're going to use. And then let's look at blood pressure. Now, blood pressure, as an example, is really fairly standard. Everyone uses a down arrow for systolic and up arrow for diastolic and puts a little dot. It's fairly universal across most health systems that you use in low-middle income countries, including your own anesthesia and ICU charts that you use at your own hospital. So the different components of this is that we have to detect the symbol, then we have to assign a value to that symbol, and then we actually have to apply a timestamp so that we can get time series data that we can then upload. And so once again, how accurate our models are. We had an old method and now we've revised our method. This is a paper that's just got accepted, that's actually in print now at BMC Bioinformatics, and this is data that we've published now. Pretty accurate in detecting blood pressure. More importantly, how accurate are we? And so this is the MAE stands for the mean average error. Well, for systolic, it's 1 millimeter of mercury, and for diastolic, it's 1.36. I mean, that variance is going to be different in the, sort of 15 people that are on this. If we actually had to look at a chart, there's going to be that level of inter-observer variability in how we define that particular point. So we think this is pretty accurate. Checkboxes, which is what that group did in terms of the circle, we use checkboxes. Checkboxes is really the game changer for us, because what we've decided to do is that instead of people writing down, oh, I had a major surgery or I had minor surgery, we've actually redesigned a chart where every element that we can discretize, we've discretized, and we've discretized it to a checkbox, because our checkbox accuracy is really astounding. And so we've realized we've worked to our strength. Our strength is not natural language processing, because I can tell you that handwriting for healthcare workers across the world is terrible. It's so terrible that even humans can understand it. Forget a machine understanding it. So there's no point that there's no machine that's going to fix that problem. And so very early on, we realized that actually if we could take written text and then discretize it or categorize it into a checkbox, we were going to actually really improve the accuracy of our models. And then we have physiological data, things like tidal volumes, oxygen saturations, the amount of blood you've given, the amount of urine you've lost. And so busy chart, but what I'm going to really focus on is some of these, the mean average errors. And you can see that the mean average errors, for example, for SpO2 is 2.81. So 95 versus 97.81, not a huge difference, right? Some of them requires a little bit more work, like our tidal volumes, about a 68 cc's for the tidal volume. And so some of the work we've done now is that we've taken this blood pressure data and we've sort of linked it to some outcome data. This was from a single center study that we did at University of Rwanda. And we actually showed that there was actually deep learning detection of blood pressure. And we used that blood pressure to then figure out how much burden of hypotension was associated with longer length of stays and higher mortality. So that's just a sort of a quick primer in terms of how data generation is before, how data is generated in high income countries, really the discrepancy between what data we have access to and what data is available to practitioners in low middle income countries. And one solution, and I just sort of showcased the solution we taking, but like I said, there are really inventive and innovative practitioners who are doing amazing work using other approaches as well. And I don't think there's one solution to the problem. I think people coming from different directions to really level that data equity gap will really improve patient care in low middle income countries. And with that, I will stop sharing and I'm happy to take questions.